and but some of the slides I have got will be useful for exam point of view. So hyperkalemia, the resting potential, the intracellular potassium is 140 milliequivalents, whereas extracellular concentration is 3.5 to 5.5. And when you talk about hyperkalemia, you have to talk about mild, moderate, and severe. How we classify based on the values of this potassium. But the common causes of hyperkalemia may be excessive potassium intake. I think all that Muthumani correctly presented. Intracellular shift, potassium release due to lysis, or potassium release from intact cell membrane, or metabolic acidosis. So this is the second method by which it happens. Third method is definitely diabetic ketoacidosis, where insulin deficiency is there, resulting in massive reflux. And lastly, impaired renal excretion, as in patients with kidney failure. And the clinical features of hyperkalemia may be primarily cardiac and muscle function disability, and muscle weakness, which can be in the form of flaccid paralysis or depressed sternal reflexes and palpitation. And the investigation modalities needed are complete blood count, urine analysis, blood urea nitrogen, to all this to find out the renal status, and blood glucose to find out the diabetic status, and ECG changes, which he described at various levels of potassium. There will be different changes. T wave peaking, shortening of QT interval, and ST segment dispersion. Then T wave flattens and completely disappears. Lastly, ventricular fibrillation occurs when the potassium level is 7 to 8 milliequivalents. And these are all the various types of ECG line drawings to describe what happens in very mild, moderate, and severe cases. And in OSCE, sometimes they give this sort of ECG for you to identify. So you can see all the QRS complex has become so wide. There is the bizarre QRS complex with the tall T waves. So this picture is repeatedly given in OSCE. So please remember this picture for identifying. This is a classical case of severe hyperkalemia. Okay, so overall, the high risk patients who are surgical patients, they can be with acute kidney injury or chronic kidney injury, or recent history of blood transfusion, patient with congestive heart failure, patient with cirrhosis of liver, or patients taking AC inhibitors or ARBs, NSAIDs, patient with severe trauma, burns, and invasive or major surgery, diabetic ketoacidosis, diabetes mellitus. So these are all the high risk surgical patients who are likely to have hyperkalemia, and how they are to be prepared before surgery. And there is a condition called pseudo hyperkalemia, which he described, occurs due to hemolysis while collecting the blood sample, and it can also occur in hereditary spherocytosis and the familial hyperkalemia, because the ambient temperature is low, intracellular potassium extrudes out. So how you diagnose pseudohyperkalemia? The answer is you have to measure the potassium concentration will be lower in plasma compared to the serum. So you have to first centrifuge and remove the coagulant factors and make the serum, and then if you see potassium will be lower in total plasma compared to serum. And to exclude that, you need a heparinized blood sample of the whole blood. So you must analyze the heparinized sample of the whole blood to identify whether this hyperkalemia is real or pseudo. And surgeries which can cause intraoperative hyperkalemia are living donor liver transplantation, parathyroidectomy, or patients undergoing kidney transplant, especially after the graft is trying to anastomose and clamp reliefs is done. There are two reasons why patient can go in for hyperkalemia: because the perfusate used will be having a higher potassium. So the donor kidney is washed with the perfusate with a higher potassium content, which will be present in the vessels of the grafted kidney, and that will suddenly surge out, and there will be there is a second reason is they have clamped the vessels, and then it's like a tourniquet. They release the vessels after the occlusion, especially the arteries. So that also contributes to hyperkalemia. So during clamp release after graft anastomosis is very important step where you can develop hyperkalemia and all cardiac complications. And temporary hyperventilation can reduce this condition, and you must avoid blood transfusions if the patient is likely to develop hyperkalemia, and intraoperative blood loss can be replaced by normal saline. And intraoperative monitoring of serum potassium, ECG, glucose level, and urine output will improve the outcome. And therapeutic options for hyperkalemia to minimize the cardiac effects of hyperkalemia, then induce potassium uptake by the cells and remove potassium from the body. These are the three basic mechanisms by which we can correct the hyperkalemia. So the immediate urgent use is calcium gluconate 10 ml 10%, and the onset of action is within 1 to 3 minutes. And insulin glucose infusion 10 units in 50 ml of 50% dextrose as the infusion. Action comes in 20 minutes. And furosemide 40 to 80 milligram, but you must make sure that the hemodynamic status is normal and the urine output is present. Then the onset of action is in 15 minutes. Then beta 2 agonists are given more as a nebulizer. It's not available as the parenteral preparation. So 10 to 20 milligrams of salbutamol is equally effect like intravenous. And sodium bicarbonate, you have to be very watchful not to be considered as a first line of treatment, because it is can cause intracellular acidosis, and sudden alkalosis will cause problem, and CO2 will be released, and that can cause acidosis and aggravate the hyperkalemia. So if at all you want to give, can give 1 ml per kg of 8.4% sodium bicarbonate. And potassium binders are given both orally and rectally as a retention enema. And but this is more for chronic hyperkalemia, not as an acute treatment, because it takes time to act, and it will bind either calcium or sodium. And so you have two types of preparations: calcium polystyrene sulfonate and sodium polystyrene sulfonate. So this K-xylate is the one which we commonly use, and some people use calcium resonium also. So you must remember the two modes of action of this calcium and potassium binders. And emergency dialysis is the final resource for patients who are experiencing lethal hyperkalemia that has not responded to more conservative line. So patients may be uh, uh, requiring emergency or urgent dialysis, but it may take time unless they have a fistula or a firm cath in situ. Initiating a dialysis for the first time for hyperkalemia will be time consuming, and during that time we can try all this pharmacological therapy. And surgical therapy may be due to hyperkalemia due to ischemic gut, require exploration, and hyperkalemia due to rhabdomyolysis also needs surgical decompression. And patient with end-stage renal kidney disease who require hemodialysis sometimes may require placement of catheter for emergency dialysis. And in solid tumors, tumor debulking may be needed sometimes to reduce the risk of hyperkalemia because for tumor lysis syndrome. So coming to oxygen cascade, this is a sequential reduction in the partial pressure of oxygen from atmosphere to mitochondria. So you can see, you must try to draw this diagram, which will make things easier for you to write in the exam and save time. So the partial pressure is 159 at the atmosphere, and then airway it reduces to 149, and at the lung level, alveolar level, it goes to actually 104, and then at the capillary it will be 100. Then as it goes through the arterial supply, it reduces to 92. At the tissue level, it will become 33. And at mitochondrial level, it is 1 to 5 millimeters of mercury. So it is a stepwise or a gradual reduction. So this wording is important. Sequential reduction in the partial pressure of oxygen from atmosphere to mitochondria. So the laws which are involved in the diffusion of gases at alveolar capillary membrane are Fick's law, which contains about the concentration gradient, and Graham's law, which is inversely proportional to the square root of the molecular weight of the molecule. So the other factors of diffusion are large surface area, thin membrane, and high solubility. So there is a formula to calculate the diffusion. This diffusion is proportional to A by T multiplied by D, P1 minus P2, where A is the area, T is the thickness of the alveolar membrane, D is the diffusion constant, and P1, P2 is the concentration gradient. So which clinical conditions diffusion is reduced? Can be reduced in pulmonary edema or in thickening of the alveolar membrane in pulmonary fibrosis. So that is about the two topics that we have been told.